as we get into therapy, it's gotten clearly, we've got a lot more we can offer now to our patients. There used to be a time when ruxolitinib was the only drug approved, and now we have 4 JAK inhibitors approved, and lots of non-JAK inhibitors and other, pathway-directed agents coming. So to get us started, I'll just give a quick overview on the JAK inhibitors, and then we'll get into also the investigational agents. So ruxolitinib, again, was the first JAK inhibitor approved for myelofibrosis, 2011. This is a JAK1 and JAK2 inhibitor, and it's associated with very clear, often dramatic benefits in terms of spleen and symptoms. Patients feel a whole lot better on this drug. It has a survival benefit in several studies. For example, the pooled analyses of the COMFORT trials, prospective registries like EARNEST, single institution experiences, real-world studies, etc. However, it causes cytopenias. It does not usually improve cytopenias, and that can be an issue. It can limit its dosing. Importantly, ruxolitinib is a dose-dependent drug. So the higher the dose, the better the spleen response, the better the spleen response, the better the survival. And because of that, to be able to dose it adequately is really important to if we are to achieve the outcomes that we've seen in the clinical trials. So this can be an issue where dose intensity can be challenged, can be compromised by the cytopenia issue. 3 things I always tell patients: weight gain, non-melanoma skin cancers, and shingles reactivation, some of the things we need to keep in mind. I give all my patients Shingrix that are going to start ruxolitinib. Fedratinib was the next one to come along, 2019 FDA approval. Now this is more a JAK2 than a JAK1 inhibitor, although it's not exclusive for either one. This drug is, in my view, a really good drug in the second line. Most of its use is in second line in the proliferative patient. In fact, we just had fairly recently the results of the Freedom 2 study, which showed that in a rigorously defined ruxolitinib failure population, you saw really impressive rates of spleen and symptom response. A couple of unique things about this drug. One, the dose does not need to be modified for platelets as long as they're over 50. As a starting dose for fedratinib, it's still 400 once a day. One has to remember the thiamine issue. There is a black box warning on this drug about Wernicke's encephalopathy. Fortunately, extremely rare, but always prudent, I think, to supplement with thiamine. Pacritinib came in 2022. Now, this drug has some additional targets like ACVR1, which is increasingly important for its anemia benefit, but also IRAK1, and this does not inhibit JAK1 at all. So it's a pure JAK2 inhibitor, and really it found its use in the low platelet patients where neither ruxolitinib nor fedratinib had actually been studied or have been studied. So again, approved for patients with less than 50,000 platelets, a very challenging population, and you see the spleen and symptom benefits really very comparable to patients with higher baseline platelets. So a tough group of patients to treat, and pretty decent results there. Now, momelotinib, was the last one to be approved, September of 2023. Now, this one is the JAK1, JAK2, and the original ACVR1 inhibitor, ALK2 as it is also called, which really downregulates hepcidin and leads to its fairly marked anemia benefit, which is not, which we see in practice, and we know that it's both being less myelosuppressive and having an actual benefit in terms of anemia. And again, it's been looked at in several phase 3 trials, even head-to-head against ruxolitinib, showing very, very comparable spleen and symptom responses. And that was, I know, a quick overview of mainly the phase 3 studies and sort of the big points. But Naseema, I want to go back to you because you guys did a lot of the momelotinib work before the phase 3. And you have this, I think, the first 100 patients on the phase 1 and 2. Do you want to give us some insights on maybe momelotinib in particular?
So we followed patients for like almost 15 years now who started on the original momelotinib studies. So it did have a good on trial. Patients stayed on trial longer because of the anemia benefits. So out of the 100 patients, 7 patients had continued on study even at the 13, 14-year mark. And then they were transitioned to momelotinib when it got approved and came on the market. I think some of the distinct features of momelotinib, it is beneficial for anemia, but it has a few downsides in terms of GI toxicity, neuropathy, especially unexplained neuropathy that I have encountered in a few patients that I've treated recently. And it can also cause elevated liver tests, amylase lipase. So there's a little bit of more monitoring that goes into momelotinib use compared to ruxolitinib. So because of those reasons, if a patient does not have anemia, my preferred agent is ruxolitinib if we are treating spleen and symptoms. And as we are getting more and more information on more anemia-directed therapies, combining those with ruxolitinib is advantageous if we want to get rid of the anemia effects. Of course, the platelets are a separate issue, and that is true across the JAK inhibitor profile, even though pacritinib is approved for patients with thrombocytopenia. In clinical practice, there are patients who will develop thrombocytopenia even on pacritinib therapy. So I think I tend to be very liberal with the platelets. As long as they're above 20,000, I'm okay with keeping them on a decent dose that I'm able to get spleen and symptom response, because we all know that in practice, a platelet count above 20,000 is acceptable, provided they're not taking antiplatelet agents or other blood thinners.
So when you say a decent dose, were you meaning ruxolitinib or momelotinib in those patients? Like which drugs were you
So
really meaning?
yes, I use ruxolitinib even if patients have platelets below 50,000. By decent dose, I mean about maybe 5 or 10 milligrams twice daily. Of course, not the 20 milligrams twice daily dose. And momelotinib as well, just because somebody is thrombocytopenic, if they are anemic. The drugs have not been compared head-to-head, pacritinib and momelotinib, but the trials do suggest that momelotinib has, even though preclinical data suggested pacritinib has more potent ACVR1 inhibition, but in the trial data, the anemia response rates were higher with momelotinib. Of course, cross-trial comparisons are always have their biases, but so that would be the preferred situation. For example, if I have an anemic patient whose platelets are lingering in the 40,000 range and I'm seeking a JAK inhibitor, I may still prefer momelotinib over going for pacritinib.
No, absolutely. And I would second that yes, there is one preclinical study that shows that PAC is a more potent inhibitor of ACVR1. But I think if one looks at the clinical data, then momelotinib has more impressive anemia responses. I'm going to come back to the point you made about the, maybe anemia drugs partnering with Rux, but for now let's pivot, Pankit, to the newer agents. We have so many mechanisms of action being explored, and you're actually leading the phase 3 study of naftamadlin, the poiesis. Then there's selinexor, there's pelabresib. You want to walk us through those drugs?
Sure thing. Yep. It will be hard to go through every drug, but let's try at least those, and maybe a line or two on a couple more beyond that. So you mentioned naftamadlin. Naftamadlin is an MDM2 inhibitor. So to understand this, we should understand that a wild-type TP53 is a good thing to have. We want that for normal functioning of our bone marrow and pretty much all the cells in our system. MDM2 inhibits the function of normal TP53, and we don't want that. So an MDM2 inhibitor, therefore, is a good idea. Naftamadlin is an MDM2 inhibitor. First studied in a 101A study where the dose and schedule were being looked into. The one that won out was the 240 milligrams once every day for days 1 through 7 of a 28-day schedule. Now that schedule and dose was studied in Boreas phase 3 study. This was a phase 3 study that randomized relapsed refractory myelofibrosis patients to naftamadlin versus best available therapy, not including JAK inhibitor. Crossover was permitted. And these results came out at ASH 2024, showing a 3 times higher spleen response rate with naftamadlin, 2 times higher symptom improvement with naftamadlin, and more symptom improvement as opposed to worsening of symptoms with best available therapy. So overall, the clinical endpoints were clearly in benefit with naftamadlin from Boreas. But not just that. The disease-modifying biomarkers, as we like to typically look into, things like variant allele frequency reduction, cytokine level improvement, bone marrow fibrosis improvement, And with navtemadlin, especially CD34 cell count reductions, these happen much more so with navtemadlin as compared to best available therapy. So all good with monotherapy, but what about in combination? And we were talking about combinations. We had just started talking about it with Rux. This was also looked into in a population with myelofibrosis patients who were on Rux and had suboptimal response. That was the 109 study. So there, navtemadlin was added on top of ruxolitinib. And it led to impressive spleen and symptom responses. Again, remember, in addition to what was already derived from ruxolitinib. So TSS50 of 32% and SVR 35% of 32% as well. This, therefore, forms the basis of the POIESIS study, which you had mentioned. It's a very unique study. It's a trailblazing study because it uses a unique design for the first time in the field of myelofibrosis. It's one of the largest studies that we are ever doing in myelofibrosis, nearly 600 patients going in with two periods. One is the period of run-in phase, where patients with intermediate 1, 2, or high-risk myelofibrosis get Rux monotherapy, and if after 18 weeks they have suboptimal response as defined by less than optimal symptom response and spleen response, so both, then those patients go on to the randomized portion where navtemadlin or placebo is added in. So it's a predefined definition of suboptimal response and at a specific time point, and not every patient will be randomized, which is also a good thing because maybe not everyone needs to be randomized. Well, that philosophy part we'll figure out with the study. So that's the navtemadlin story so far. POIESIS is very early in enrollment, but what about some of the other drugs? You mentioned about MANIFEST-2 with pelabresib. Pelabresib is a BET inhibitor, first studied in MANIFEST, where it was studied as monotherapy in patients with suboptimal response to Rux as an add-on therapy, and also in frontline with Rux as the backbone, not to mention essential thrombocythemia patients. So that then led to MANIFEST-2 study, where patients who were JAK inhibitor naive, had intermediate 1, 2, or high-risk myelofibrosis, they were randomized to Rux monotherapy, well, Rux plus placebo, or Rux plus pelabresib. First and foremost, the results came out at ASH 2023, and a very impressive near doubling of spleen responses was seen. I believe that the numbers were 65.9% versus 35% or so, in line with the phase 2 data. So that was excellent to see. The symptom improvement data also showed that there was numerically more symptom improvement with the Rux-Pela combo as opposed to Rux, but it did not meet the statistical significance. Well, if you took fatigue out, maybe it did, but as it was defined with the key secondary endpoint, it didn't. That said, bone marrow fibrosis improvement was more so. Rux-Pela also blunted the anemia-causing effects of Rux. The cytokine data that was reported also showed that there was more decrease of cytokine levels, like the NF-kappa B pathways, IL-6, IL-8, TNF-alpha with Rux-Pela as opposed to Rux alone. And the dual responses of spleen and symptom were more so with Rux-Pela as opposed to Rux. The problem that it also ran into, like we already mentioned, was the symptom part, and then there's a slightly high leukemic transformation rate when you take both the accelerated and blast phase transformation rates with pelabresib plus Rux combo as opposed to Rux alone. Now we'll have to see the long-term data and see whether we need more studies or if MANIFEST-2 itself would suffice. But that's the story with pelabresib. The third one is selinexor. Selinexor is already FDA approved in other cancers, including heme malignancies like multiple myeloma and DLBCL. But it's approved at a much higher dose. In the journey of myelofibrosis, it was first studied in a second-line setting, followed by a phase 1 portion of what's now a phase 1, phase 3 study. In that phase 1 portion, newly diagnosed myelofibrosis patients got either 40 milligrams of selinexor once a week or 60 milligrams of selinexor once a week. And what was very impressive to see was some of the highest rates of spleen volume reduction that we have seen probably across any phase 1 study. So 79% with Rux plus selinexor, and a very impressive 58% total symptom score decreased by 50% or more. So these were very impressive. Additionally, of course, there were some other impressive biomarker-related data that also came out, like cytokine decreases and additional things. We don't need to get into all those details right this minute, but all of those wonderful results from the phase 1 portion led to the phase 3 portion, the Sentry clinical trial, as we call it now, still enrolling, and that is a study that's enrolling intermediate 1, 2, or high-risk myelofibrosis patients and randomizing those to Rux plus placebo or Rux plus selinexor with 2 antiemetics in the first couple of cycles.
So designed a lot like Manifest 2 in the sense that intermediate 1, 2, and high and frontline combo.
Absolutely. So these are the 3 big ones. Now, of course, there are some additional things which are ongoing in the field.